Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Shirin Towfigh. She's a surgeon and hernia specialist. Today's Kevin MD article is Ignored and Misdiagnosed: The Truth About Hernias in Women. Shirin, welcome to the show.
Thank you so much, Kevin. It's my pleasure. I listened to your show.
Oh, I appreciate it. And
Yeah,
where are you based out of?
I'm based out of Beverly Hills and I have the Beverly Hills Hernia Center.
All right. So, how long have you been a hernia specialist? And tell us what a typical day is like.
Sure. So I'm a general surgeon and I've started my practice in 2002 and I've been exclusively doing hernia since 2008. So my typical day is seeing patients with hernia-related complaints. About 80% of my practice is revisional or someone's had a complication. I also am a little bit of a curious person. So many patients are sent to me because no one can figure out why they have abdominal pains or groin pains or pelvic pain. And then I try and figure it out, tell the doctors what to do, and then I enjoy those puzzle solving situations.
So, what made you specifically focus on hernias as a career?
We were discussing, everyone asked me that, first of all, especially patients sometimes, because I'm female. They're like, why did you go? How did you get into this? So it definitely did not sprout early on. My goal was to be a laparoscopic surgeon, and that was my first job. But I started inheriting patients that had very complex hernias, and I noticed I needed a little bit more education on it and to learn more. And I was really interested in it once I got to learning it through the American Hernia Society. I got to brush shoulders with people that I learned from in the books, like Schuldeis was there, Amid was there, Condon was there. These are all people, Nihus and Condon have a great book on hernias. So all the people that I read about were at this meeting and I was really inspired. So, and I was the only female at the meeting. So I had just graduated. They already came up to me and said, hey, would you like to be an editor for our hernia journal? We've never had a female before. I was like, absolutely. So it kind of started like that. They were very loving and inclusive and interested in seeing younger people. Now I'm kind of one of the older people in the society,
Mhm.
but it's nice to see that kind of what I really enjoy right now, more and more people are enjoying, and it's becoming a bona fide subspecialty within general surgery.
So, we're going to talk about your article a little bit, but let me ask this
Yeah.
question. What is what you would say the biggest misperception or misconception about hernias that we should know about?
That is just a hernia.
Hmm.
That is the worst. We say it all the time. Oh, it's just a hernia. And so surgeons for sure don't typically spend a lot of time and energy perfecting their knowledge and their surgical technique for hernia repair. And it's not really considered a very kind of fancy or kind of sexy part of general surgery. And other specialists, gynecologists, urologists, other doctors that may even like general medicine doctors, they may not understand the importance of diagnosing a hernia because maybe it's a female. Oh, women don't get hernias, some people feel, or it's not a big hernia, so it can't be the cause of your problem. Maybe it's all in your head. There's a lot of misconceptions about what a hernia is, who can get it, and then what's the best next plan of care.
All right. So, you're going to talk about more about that in your Kevin MD articles titled
Yes.
Ignored and Misdiagnosed: The Truth About
Hmm.
Hernias in Women. So, tell us what led you to write this article and then go into the article itself for those who didn't get a chance to read it.
Well, June is Hernia Awareness Week. Believe it or not, we have a whole month.
Hmm.
And usually on my own social media, I would say something about it in the month of June. But I am a big follower of Kevin MD, and it's a nice way to kind of get information out there that's kind of from the heart. So I'm like, I have so much information to share, and you can only do so much at meetings and writing articles, or we have a book even on groin pain, but people have to read that. And I felt this would be a nice audience to share my thoughts in a very concise way.
All right. Tell us what the article was about for those who missed it.
Yeah, so I basically filled the article with as much information as I can that will be relevant to the typical doctor or even patients. So understand that most people know hernias is to be a bulge, and oftentimes they don't consider it to be a painful bulge. But if you're female, younger, thinner, don't expect to see a bulge. They may present first with pain and not with a bulge. Also, especially in the groin, if you have pelvic pain, chronic pelvic pain, there are a lot of atypical signs of hernias that are due to the hernia and not due to something else. So you can have hip pain, you can have pain radiating into your inner thigh, around your lower back. All of these are symptoms of a hernia. You can have urinary frequency, pain with intercourse, pain during your menses. These are all findings that are consistent with an inguinal hernia. Bloating, nausea. These are all symptoms. You don't have to have an obstructing hernia or a strangling hernia to have these symptoms. So what happens is patients, typically women, typically younger people, go to their doctor with these vague symptoms. Yeah, I got this like lower abdominal pain or pelvic pain. If you're female, you get sent to the gynecologist and they treat you for endometriosis, ovarian cysts, vulvodynia, because a lot of your pain is not like your typical bulge in the groin. Whereas I'm hoping that people who treat patients with pelvic pain, not to dismiss hernia, because hernia is probably the most common reason for the pelvic pain, because it's so much more common than all these other diagnoses I told you about.
So specifically in women, you mentioned younger women. What other risk factors do women have to worry about that puts them at risk for hernias?
Good question. So hernias do run in the family. It's very genetic based. If you have a female in your family with a hernia, you're more likely to have a hernia than if you have a male in the family. So it is also sex based in some manner. Then there's lifestyle. So obese patients, chronic cough, constipation, anything that requires straining. If you have an enlarged prostate or you're straining to urinate, those are all risk factors for getting hernias. Nicotine use has been associated with worsening collagen and may accelerate your hernia. It shouldn't cause a hernia. Obesity, again, if you have a tendency towards a hernia, being obese may also make it more likely for you to accelerate development of your hernia.
And when you say younger women in particular, what particular age groups are most at risk?
Hernias in general is a disease of the older population statistically, but what happens is when you're younger, people don't think about hernias as much, and so they they dismiss some of your pelvic pain complaints as gynecologic, or if they can't figure out why it's gynecologic, then it must be in your head.
Mhm.
So my concern is that women are being dismissed and being given this chronic pelvic pain diagnosis, which is kind of a like anything can be chronic pelvic pain. Whereas if they're just diagnosed with a hernia and you treat the hernia, that's a cure. And our studies have shown that women have about a 2-year delay in diagnosis compared to men. They're more likely to be on narcotics preoperatively than men prior to their hernia repair. And they're much more likely to have a better outcome with less chronic pain from their hernia repair than men. So think of hernias when you think of pelvic pain.
So, in the exam room, and as you and my listeners know, I'm an internal medicine primary care
Yes.
physician. So, if I have a female in my exam room exhibiting some of the symptoms that you describe, and because I'm hearing you and I'm thinking of hernia now,
Yeah.
and clinically, like
Great.
you said, they don't have that stereotypical bulge that's associated with hernias, what will be the next step? Would it be some type of imaging study, any type of physical exam findings that could elucidate that? What would be the next step?
Absolutely. So examine your patient's standing because the gravity will help elucidate a larger hernia. If you don't see a bulge, then palpate the inguinal canal. And that's basically a line from the anterior superior iliac spine down to the pubis. Along that line, if there's any fullness or tenderness, that's very, very, very sensitive finding for an inguinal hernia. And then if you're still not confident that they have a hernia, do get imaging. There's only 2 good imagings you should order for patients with groin pain to rule out an inguinal hernia, especially an occult one where it's not very obvious. One would be a hernia ultrasound. Specifically, have to say dynamic hernia ultrasound because that's a specific protocol
Hmm.
where they will have the patient move around, do bear down, and they'll really look for an inguinal hernia. If you order an abdominal ultrasound or anything else similar to that, it will not show a hernia, most likely. And then the other one is an MRI. So MRI pelvis, no contrast, just a straight MRI would be great. On my website, we have our MRI hernia protocol, which many institutions around me are now using, which is a Valsalva MRI. So it's a
Mm.
dynamic MRI looking at the pelvis. You have to order it as a soft tissue MRI. Otherwise, they'll tell you about the bones and the pelvis and the sacrum, and they'll miss the fact that there's a hernia.
And no role for CT.
Not very much. If it's an obvious inguinal hernia and you want to look at contents, or if it's a ventral hernia, abdominal wall hernia, CT scan's very good for that. Um, but we've looked at the benefit of CT scan in these occult hernias, and it's horrible. So we found for ultrasound, it's about 50% true negative and 100% true positives. So ultrasound is great if it shows something. If it doesn't show it, you should move on to MRI, where the sensitivity and specificity is over 90%. It was in the single digits for a CT scan.
So we focus more on inguinal hernias. What about umbilical hernias and abdominal wall hernias? Are they underdiagnosed in women as well?
Not as much. I think we appreciate that women are predominantly the ones that get umbilical hernias. Pregnancy can see a little outy, and most ventral hernias and umbilical hernias do not need surgical attention if they're not symptomatic. Whereas in the groin, especially in females, you must make sure you're not missing a femoral hernia that's causing their groin pain as opposed to an inguinal hernia, because that is a life-saving procedure if you address a femoral hernia in a female.
So let's say we order that MRI or an ultrasound and confirms the diagnosis of an occult inguinal hernia. So the next step, is it a referral to a surgeon like yourself? Is there a role for conservative treatment? What should I do next?
So for ventral hernias, watchful waiting is considered safe for most umbilical hernias unless they're symptomatic, in which case you should send them to a surgeon. For inguinal hernias in males, we have good studies to show that watchful waiting is considered safe for asymptomatic, so no symptoms, or minimally symptomatic inguinal hernias. And the prediction is you may have a 0.18% per year risk of incarceration if you do choose not to have surgery. If you do have symptoms, surgery is recommended. And about 2/3 of patients will require some type of surgery within 10 years of their diagnosis. Women's a different situation. We have zero studies looking at women. Of the past major six randomized controlled trials looking at inguinal hernias, only 7 women have been enrolled. Most
Mm.
studies have had 0 women. So we don't understand the chronology of women's hernias. What we do know is that women are 10 times more likely than men to have femoral hernias, and femoral hernias can kill you. So if you have an emergency from a femoral hernia, you have a 5% chance of death, and that's the highest risk of any hernia we ever talk about. So for women, it's very important that you rule out a femoral hernia. Now, for surgeons, that's our role during surgery. If you take a patient to the operating room, to make sure you don't miss a femoral hernia during your surgery, which is why laparoscopy is so great for that. However, uh, we don't know. There may be a role of just with imaging ruling out femoral hernia and then saying, okay, you don't have a femoral, you have an inguinal hernia. It's not bothering you that much. Come back to me when it's bothering you. We don't know if that's valid. We know that's valid for men. There's a group out of Michigan that's hoping to study that and repeat the same studies that were done for males on females. And so hopefully soon in the next couple of years, we'll have a watchful waiting trial that will enroll women.
And can a femoral hernia in women be differentiated on imaging?
On imaging, yes. On examination, it can be difficult.
So in terms of repair, what's that process like for patients?
Oh, well, they have a lot of options. In the United States, mesh-based repair tends to be the typical way to do it, but you have open, laparoscopic, or robotic approaches. You can have it with mesh, without mesh, and we have a wide range of meshes nowadays. So if you go to your general surgeon, they usually have a type of hernia repair they like to do. If you go to a hernia specialist, we tend to have like more tools in our toolbox, so to speak, about different options that we can tailor to your needs.
So what kind of additional options would a hernia specialist like yourself have in contrast to a general surgeon?
Well, for example, if you come to me and you're morbidly obese and you have a big scrotal hernia, I'd probably err on mesh repair with robotic approach. If you're a ballerina or a yoga instructor with a small hernia, I probably will do a small open repair with no mesh. So there's different types of hernias. If it's a recurrent or larger hernia, we err on thicker, stronger meshes. If it's a more typical hernia or a smaller hernia, you can err on using lighter weight meshes.
Mhm.
There are people with autoimmune disorders, so lupus, rheumatoid arthritis, that are potentially prone to react to the inflammatory process that a involves, and they can get an autoimmune or inflammatory response to it. We call that mesh implant illness, and I published on what mesh implant illness is and who's at risk. And in our population, 80% of the people that had mesh implant illness had some type of autoimmune disorder themselves already. So I try to prevent use of implants in that population, but we don't really know from a population standpoint how many people will react to mesh given that kind of personal risk factor.
And in terms of outcomes, what is the percentage of recurrence after repair?
Very surgeon specific.
Hmm.
There are great population studies out of Denmark, Sweden, and Germany, which shows the recurrence risk for a laparoscopic repair should be around 1 to 3%, and for an open repair, less than 5%. Hernia specialists should bring that number down and bring the risk of chronic pain with repairs below that level. So that's really what differentiates a specialist, perhaps, because we tend to tailor our care.
So, what do we have to look forward to on the horizon when it comes to hernia treatments over the next year or so?
Maybe not over the next year, I would say over the next 10 years.
Hmm.
Hopefully, more data to support evidence-based hernia repairs and hernia care for women. Hopefully, better meshes. We're slowly moving away from permanent inflammatory synthetic meshes. They're hybrid meshes now. I have a couple patents on gender-based meshes. I feel that the female pelvis is very different than the male pelvis, and so our surgical technique, including our mesh design, should be different. So hopefully we'll have a lot more tailoring of care to improve outcomes.
We're talking to Shirin Towfigh. She's a surgeon and hernia specialist. Today's Kevin MD article is Ignored and Misdiagnosed: The Truth About Hernias in Women. Shirin, let's end with some of your take home messages that you like to leave with the Kevin MD audience.
Number one, it's not just a hernia. Do treat it as you would any serious disease. Number two, do your research. Most of my patients are highly educated when they come. Number three, pelvic pain is most likely not purely gynecologic, and do consider a hernia in your differential diagnosis, because that's a very treatable way to handle groin hernias. Number four, I don't believe in overtreating, so watchful waiting and educating patients on risk factor adjustments, such as treating their chronic cough, constipation, or prostate enlargement can be very helpful. And the one thing we didn't discuss is exercise is great.
Hmm.
It's protective. You can do sit-ups, push-ups, lift weights. Those are all great things and will not hurt your hernia, but may help you control it.
Shirin, thank you so much for sharing your expertise and perspective. And thanks again for coming on the show.
Thank you, Kevin. It's my pleasure.